Thank you all so much for attending. My name is Lucy Jesus from Palliative Care Tasmania, and I'll be your facilitator for today. We have the privilege of hosting Dr. Megan Hanley, speech pathologist from the Tasmanian Health Service. We thank her sincerely for her time, insights, and for joining us today. We'd like to take a moment to acknowledge the Palliative people as the original custodians of Lutruwita, Tasmania. At Palliative Care Tasmania, we acknowledge the Palliative people's deep connection to family and community and their enduring strength and compassion in caring for their sick, dying and grieving. I would also like to take my deepest respect to their elders past and present and that respect to any Aboriginal Torres Strait Islander people who may be joining us today. If you have any questions you would like to ask Dr. Hanley to address, please submit it during the session and Megan will try to answer them during and after the presentation. Please use the Q&A icon at the bottom of your screen to submit your questions. So please join me with a warm welcome as I introduce Dr. Megan Hanley.
Hi everybody, thank you so much for having me here today, Palliative Care Tasmania. I think I've already stuffed up the slides. Someone's just about to help me with that. Fabulous. Hopefully, if there's any problems, let Luke know. So again, thank you for having me. And this is a fairly niche topic. So very appreciative of Palliative Care Tasmania giving me an opportunity to talk to you about that today, but also your presence in being interested in it. So welcome. I just want to give you a bit of background on me. So I'm in a fairly unique position in that my position is a training and education and support service focused mostly at carers, so formal carers in particular. And it was developed many years ago in response to requests from the community that people with communication and cognitive difficulties and swallowing difficulties, which are the three areas that speech pathologists work with, that they would get people with speech pathology reports and be there to support them, but they actually needed a lot of education themselves to understand how to support people. So that was the job that I was focused on and have been for several decades now. And in that, what's come out of that is that choking and how to manage that's been a huge issue for carers and for the person, obviously, who is at risk of choking and their family members. So as a result of that, the Tasmanian Health Service Speech Pathology Department developed a choking management service to specifically address those issues for people. And certainly the things that have come up over the years, and I have had the great privilege of spending hundreds of hours with hundreds of people talking about what living with choking risk is like and what trying to support someone living with choking risk is like. And from that, lots of things came up that I couldn't really respond to. So I went off and did a master's in bioethics to try and get my own head around it, some of the issues that were coming up, and also did a PhD on looking at the social context of choking and the implications to care. So that's kind of my background that's brought me here to this session today. But I'd like to, before we launch into it, really acknowledge that behind the knowledge and challenges being presented today are people like yourselves who might be managing or caring for people at risk of choking, and just acknowledge their generosity and honesty in sharing what it's like for them and the fears and anxieties they have around working in this area. Also, those who are at choking risk and their families who have also been amazing in sharing what it's like for them. And through the many choking deaths that we have had, and those people and those carers and families whose stories have been represented in coroner's reports and police reports. So really standing on the shoulders of giants in the people who have shared so much with me over the years. So I just really want to acknowledge that. Hopefully what I'm going to do is represent them today and the kinds of issues they have. So this session I'm sort of divided up into two. The first part, we're going to look about what makes choking risk so challenging for everybody, and what decisions people make around choking risk. And then we're going to have a break. So after slide 5, we're going to have a bit of a question time if you wish it. So just think about that. If questions are coming up early on, then please put them in the chat and Luke will manage that for us all. And then in the second part of the session, I'm just going to be talking about and exploring with you if people do have choices, and we've identified what those are we able to manage them? And so looking at some of the issues that might be around that. So just to really start us off, because it's a bit of a new or what would I say? It's an emerging area for speech pathologists to work with palliative care. So I'm going to give you a bit of my impression based on the work that I've done. So speech pathologists, as I've already said, work in communication and cognition and swallowing areas. And so we're talking mostly today, well, we are talking about adults. So of course, children can come into the palliative care framework as well in this area. But specifically talking to that, it will depend on the speech pathologist's role, who their client groups are, and the settings that they're in, how much exposure they get to palliative care and its principles and the amazing people who do work in that area. And often our most contact is through when we're working with people with life-limiting diseases, so people with neurodegenerative diseases like motor neurone disease, Parkinson's, dementia. And so that's often where we have a lot of contact with palliative care. And when we enter in the palliative care framework, I guess we're shifting from what is traditionally our rehabilitation, treatment, management role into a very different framework where we're looking at sort of how can we maintain function and how can we help the person adjust as they move through the grief of loss of function and to end of life. And that may be directly with the person with the issue who has the life-limiting illness, but it's also with family and team members, care team members, as to how we can contribute strategies and help with communication and managing cognitive issues when people are trying to do end-of-life planning, and in relation to swallowing, shifting maybe from a risk approach, a risk management approach, to a more quality of life, what they want to have as part of their life experience up until their death. So there are specific speech pathologists who work in palliative care, and I apologise if I haven't represented their very specialised roles, but certainly we do have relationships with palliative care, and the ones I've had have been amazing. So hopefully that just gives you a bit of a overlook at where we might fit. So what I'm going to do with the next slide is we're just going to talk a bit about what makes choking so challenging for everybody. And as someone who does education, I know that giving a slide with this much information on is probably very inappropriate. But I have done it specifically because I want you to feel or recognise that feeling of, whoa, okay, that all seems a bit much. And choking's a bit like that. It is so multifaceted and so many levels to it. So I'm going to run through these things reasonably quickly, and I just want you to sort of get a sense of how your brain is reacting to that of, oh, well, yes, yep, that's because this is what everybody has to consider when they come to this area, whether it's the person who has been identified as being at risk of choking, and then their family members and carers. This is the kind of stuff they have to try and integrate in order to move forward with how do we then live with choking risk. So sort of just to begin with, anyone can choke. People with swallowing problems may be more at risk of choking, but they actually may not be, because they often can be quite mindful of their difficulties, and so take a lot more care than maybe we do at the family barbecue, where we're laughing and drinking and sort of focusing on other things and get ourselves into trouble with an obstruction event. And not everyone with a swallowing problem will experience choking events. The big one, of course, is that choking can be fatal, but choking can also be reversible in a lot of situations. And so, how do you balance risk and how do you manage your reactions to it when you've got something that is so absolutely devastatingly terrible, or something that can be easily reversed with a hit on the back for some people. So people with swallowing problems may have a choking event or events and don't die from choking. The first time someone chokes with or without a swallowing problem, it can be fatal. So you've got some information saying, well, you can have choking events and you recover, but we never know in any one particular event whether that will occur or not. People who choke can suffer brain damage and end up on ventilators, and so many of them may want to make decisions about that, how their life ends and what that's like for them and for their families in contemplating that. Also, in the area of managing risk and harm, choking's multifactorial, so identifying all the factors contributing to choking events may not be possible. If all the factors are identified, not all factors may be controllable because of quality of life choices or circumstances. And there's an example in one of the coroner's reports that I read as part of my research, where there was a woman who obviously had swallowing problems because it was reported how amazing her care was. Everything, it was like a gold standard in speech pathology. Everything was being supplied. She had texture modified food, she had supervision, she had aids to help her eat, she had beautiful positioning. Like, really, if we were going to reduce risk, that's everything we could do. And she was in the dining room one day and somebody dropped a tray behind her when she was eating, and she, in the fright, inhaled, choked and passed away. So, we like to control things, and when you've got something like choking where there's such risk and so much at stake, control is even something you want to do more and more of, but we can't control for everything. And certainly people's quality of life choices means that there may be factors that we won't be able to control. And if that wasn't enough, dealing with all of that complexity, successfully managing a choking event is multifactorial. So if we haven't been able to stop a choking event happening, just the applying of first aid and the environments that we have to do that in and the people that might be involved in that, so family members, the size of us and the person. If we're trying to do first aid on a very huge man, that's going to be more challenging for us if we're middle-aged women or young women who, don't have a lot of inherent strength. So successful management of choking is going to depend on lots of factors. And again, not all factors may be controllable. Texture modifying someone's food may reduce choking events, and sometimes we have people who are having choking events, and modifying their texture makes a huge difference. But it is possible to choke on any kind of food texture. So there is no universal safe texture. And back when I started speech pathology, it was so comforting because we thought there was a universal texture and it was puree. So if you were ever on doubt, puree was something that people were put on. And it is fair to say put on not appropriately, because we often used it as a universal. But actually our research now shows that people can choke on purees. So if you're a carer providing food and doing assisted feeding for someone, safety, and there are no guarantees. So there's the stress for carers as well as the person who is at risk of choking. And if that wasn't enough, some texture modified food may reduce the risk of choking, but if choking occurs, some of those textures may actually impede successful clearing of the airway. So these are the kinds of things and background information that when people are making decisions about their choices, and we sort of are trying to express the benefits and the burdens of different choices they could make, that they're juggling. And in addition to that, particularly for formal carers, what happens after a choking event if somebody dies. And in Australia, choking is a reportable death to the coroner. So there are coronial investigations that go on with that. And just that threat of that coronial inquiry and police involvement can create a lot of fear in people. And I certainly have had family members who have said to me, will they be in trouble if they give the wrong textured food to the person that they're caring for? And that's family members. And you can imagine how formal carers also feel those stresses for that. So choking is anxiety and fear provoking for those experiencing it, for those observing it, for those preparing food for people, for those who are doing assisted feeding, for those applying first aid, for those who are managing organisations that are trying to juggle the anxieties of clients and families, but also the anxieties of staff as well. So because of all of those things going on, supporting choice and quality of life and death in the face of choking risk gets really complicated. So what are the choices that people make around care and death when faced with choking risk? Some of these are probably going to be familiar to you, and they're choices that are not necessarily just made by people with life-limiting diseases, but certainly in my experience of working with people with life-limiting diseases, these are certainly things that are choices that they make around. So choices people might make about reducing risk is to have a texture modified diet, either food or drink, to have someone there with them when eating. Formally we'd call that supervision, but really we're just meaning having company there. Having somebody who can assist if they do get a choking event, having someone assist with them with eating and drinking. And some people will choose to cease oral feeding or drinking and have peg feeding. And of course, the reasons around this will not just be about choking risk, but certainly these things are in particular identified when people are contemplating that they might risk, particularly if they're having choking episodes. The flip side to that is the decisions that come from a place less about risk and more about quality of life. And we sort of just have to pause here and realise that reducing risk for some people is quality of life for them. So we kind of talk about quality of life as being when we don't follow risk reduction strategies, but it's both. It can be both. And so for our people to follow they don't want to follow a recommended texture modified diet, or to have a texture modified diet at a level acceptable to them. So they're making choices about what they're eating or drinking, which basically goes against the recommendation for safety at times. And while they may feel comfortable with those decisions, and in person-centred care, of course, we would be providing hopefully the environment where they will feel comfortable about those. It doesn't necessarily mean that the family and the formal carers are comfortable, because they are in the position that those decisions might actually mean that they're going to have to respond to something that they're very scared of responding to, and that's a choking event. Mostly, in my experience from talking to people, they will refuse texture modified diet, but usually accept other risk reducing strategies. But certainly there are people who won't have someone supervising them when eating, don't want to be assisted with eating and drinking, and even with severe swallowing difficulties will want to combine non-oral feeding with drinking and with pleasure-based oral intake. So the kinds of reasons, and maybe just take a moment to think about what choices you would make if you had been identified as a choking risk and had life-limiting illness, and what your reasons might be for choosing those things. And I guess the obvious ones with the risk reduction are around they don't want to choke, or they're afraid of choking, or they're wanting to reduce choking events. And sometimes our people aren't at high risk of choking, but their fear is incredibly high. So certainly with the choking management service that we set up, we address people at the fear level, even if they're actually not having choking events. And the decisions they make are about their psychological comfort as well, whether having someone being there when they eat is reassuring to them. And for those who are choosing more quality of life experience choices, they're looking at things like what gives them pleasure, what kinds of things add to their normality with diseases that might be taking so much away from them in other areas of their life. So these are the kinds of the choices that people make, in my experience of what they've told me that they want to make. And sometimes those are very challenging to make possible for them, given the different settings that they're in. So the next slide, this slide just looks at the choices people make around risk and end-of-life care when facing choking risk. And sometimes I think probably we don't spend enough time looking at this area, mostly because it gets a bit deep when you start looking into it with the multiple layers that are involved in sort of teasing out to find out what people want in this area. So I guess the easiest thing is if they want absolutely everything. So they want first aid techniques applied if they have a choking episode, which could mean hits on the back, chest thrusts, and CPR. and to have all advanced assistance possible. So paramedical with the ambulance arriving, medical on the scene or in hospital. And so they're kind of that's our default response anyway. So that's fairly easy to support and manage. But we're getting more and more as we look at advanced care directives and advanced care planning before a directive's actually made, about people's choices of end of life when they are living with choking risk as part of their life-limiting illness. And so I've had lots and lots of conversations on death, and people have really guided me as to what kind of decisions that they want to make. And so these are what I'm presenting here. That some people want to have first aid, plus or minus CPR, and we'll get to that a little further on in the session, to help their family. So their family is allowed to do all of the first aid, but when the ambulance arrives, they don't want the ambulance to do CPR or resuscitation, and I'm going to use those words interchangeably, and they may or may not want it in hospital. Some people will say they want the first half of choking first aid, and what they're meaning there is the hits on the back or the chest thrusts, but not CPR regardless of who is present and the level of aid that's present, so whether it's ambulance or family, and to not have any first aid techniques or resuscitation, and just to have medication support to manage the stress of a choking event. So that last option of to not have any first aid techniques, I've only come across a handful of people who don't want at least the initial support of having someone try to remove the obstruction. But there are people who don't want that, and that's when the skills of palliative care and medication and how we try and make that as good a death as possible comes into it. So that's kind of given us a bit of a framework of choices people make, and I suspect some people may be familiar with those, possibly not for all of those. So we might sort of just open up to some questions now, if there are any. Otherwise, I will keep going.
We do have a few, so I'll just start from the top, might be the easiest. Do you have any information or links for service providers before accepting decisions for quality of life?
So we're talking really in general about processes and stuff. I'm just sort of trying to unpack that question. It will depend on what setting you are in. Generally what we're talking about, I'm thinking, is decisions and whether people can make quality of life decisions. Can the person just give us a bit more information on that? Because there's a lot of ways there's a lot of answers to that. So I'm just thinking maybe that's something I can answer in an email afterwards, because it will depend a little bit more on it.
We can do any follow-up information that needs to be sent out. I'll get you to contact them, Megan. We can pass that information through after the session if that's a bit easier.
Yeah,
that's no worries.
I might come back to it as my brain's thinking as we go through questions. It might make it clearer.
No worries. How do you manage people who are afraid of choking and refuse to eat?
Yeah, it's really hard. And that's when things like texture modifying food, having someone doing, one-on-one supervision and support, and assisted feeding if they do need that, might be some ways of reducing that, so providing that comfort. And then I guess we're looking at non-oral feeding as an option if we're in that situation with people who just may be so frightened that that's the only way we can offer them food or drink.
Are there particular types of life-limiting conditions that mean the person is at higher risk of choking?
Certainly in the research that I did, the people who most likely to fatally choke are people with dementia and people with severe mental illness. So mental illness not necessarily being a life-limiting illness in the context that we might be talking about physiologically. So those are the ones who are most likely to die of choking. Those who are most likely to have choking events, if there's a swallowing problem and if there's cognitive difficulties, those are going to be two things that certainly exacerbate choking and quality of life decisions. That means that we may not be able to reduce risks, is also going to be a factor.
Thanks, Megan. One from Diane. How do you manage the tension between a person choosing to eat or drink with acknowledged risk and the impact that that choice has on the people supporting them?
Yeah. I think what we have to do is just acknowledge that when we're talking about person-centred care in regards to choking risk, we are talking about a huge ripple effect. So that when somebody makes decisions that are not going to reduce risk, that's going to ripple out to family members and ripple out to carers as well. So our approach in why we set up a choking management service in the first place was we're doing person-centred care for everybody. So we're doing person-centred care for the person who's at risk of choking. We're doing person-centred care for the family and for the formal carers. And what it looks like for the families and the formal carers is they need a lot more information. So they need information about that. Really, if we put in all of the risk-reducing factors or strategies that we do now, we still won't necessarily stop choking happening. We can never guarantee we can prevent choking. So we train people, we capacity build people to be able to do choking first aid, and we do choking first aid not as the 5 minutes that you do in a general first aid course, but we go through every possible process or situation that they might face in if somebody chokes. How do they do it if it's in bed? How do we do it if it's in a wheelchair and the person's strapped in? So all of those permutations. If it's family members, we do it specifically tailored to that person, and we also tailor the first aid to the abilities of the carers. So I've lost the track of the question. See, I should be reading. Has that answered?
Yeah, so the question was, how do you manage the tension between a person choosing to eat or drink with acknowledged risk and the impact that that choice has on the people supporting them?
Yeah, okay. So, thank you. I had missed a rather major bit in that. If we're talking about it in supported accommodation, we have to have a lot of policies, documentation, very clear guidelines, very clear processes around that, so that the tension that arises, or that we can dissipate that tension, and that we're not blaming the person who's made a decision for their quality of life for actually creating more anxiety for us because we're, providing them with food and things like that. So we have to look at the fear, look at the anxiety, and putting all kinds of supports in so that carers feel more comfortable and feel that they are doing their duty of care in supporting very challenging quality of life decisions that people might make. So the fact that you've asked about the tension is fantastic, because there is an acknowledgement there that there is tension, and there is. And now we have to sort of start taking that apart and looking at where's the tension coming from and what can we do to support the person.
Thanks, Megan. And the last question is from Fran. Is there a preferred dignity of risk form/waiver when a person chooses to risk feed that can be used so that formal supports and the person feels that their choices are considered and the formal supports feel covered legally?
Yeah, okay, great. So that's probably coming back to, I think, maybe Julie's question that, sorry, Julie, I fobbed that off because there were so many sort of things going on with that. Again, it will depend on the setting, and the answer is yes, there are. We have them in hospitals, and I'm not sure if everybody in this session today is based in Tasmania, but we have processes around that, certainly in the public service. I have seen aged care facilities have terrific guidelines on that. The legal stuff we're actually about to come up with, because that's often connected with coroner's reports and what retribution might happen if we actually support people's quality of life risk. So I haven't given you a direct answer to are there things other than to say yes, there are, and we would probably need to tease out what settings people are in to sort of direct you in the right direction. Certainly when you look at advanced health directives, WA brain here because I'm working with mum with her advanced health directive, but it's an advanced care directive in Tassie. Apologies for that. You know, when you look at those kinds of areas, they can support with end of life decisions. But yeah, certainly speech pathologists are much more familiar now with those kinds of discussions, and I think we probably need to go on to the next section of the presentation and maybe that'll be covered a little bit better. A bit more.
Right. I think that's a good transition because that is the last of the questions so far. We will have a Q&A at the end of Megan's presentation. So if you do have any other questions, keep popping them in the Q&A, but I'll let you go from here, Megan.
Thank you. Okay, so I think it might be just a bit helpful to look at when someone dies of choking, because often these fears about feeding with acknowledged risk or supporting with acknowledged risk is, you know, what's the outcome? What's the end game? You know, what if we do have a choking event, and what if we and that leads to a death? So I want to just touch on coroners, and because, wow, when I started doing research on coroners, did that change my whole view around quality of life and risk? So I want to try and share with you some of the comfort that I got from looking at coroners' reports and how they approach duty of care in this area. So I'm hoping that that will be helpful. And I'm going to go through it quite quickly because I am aware of the time. So I'm going to present two cases here that will just sort of really tease out the defining features that I have seen in coroners' reports. And in my research, I looked at over 250 coroners' reports. So Ian was 47, living with a neurodegenerative disease and had difficulty swallowing, and Ruth was 74, living with the after effects of stroke and difficulty swallowing. And so there was a coroner's investigation into both these cases. Both were living in an assisted care setting. Both had decisional capacity. Both were provided with texture modified food in their care setting. Both were supported to eat their preferred food, which was not texture modified or not the recommended texture modified food. Both had access to an emergency bell, and both were alone eating their preferred food when they choked. Okay, so some of that may be resonating for people if they've come across these kinds of situations in their work. However, this might be interesting. So One of the coroner's conclusions was, it is clear on the evidence before me the deceased received impeccable care and support whilst living at the nursing home from both the staff of the home and from their loving spouse. And the second coroner's conclusion on the second case was the deceased's death was accidental but preventable. It was a direct consequence of the nurse's decision to permit deceased to eat a meal which contravened their soft diet. So, first ask yourself, which is the one that we're scared of receiving as a coroner's conclusion? And then we're just going to go back and touch base as to which one do you think went with which case? Was it Ian's or Ruth? And what I'm going to do is share some of the features of this case, these cases, to see, what we get out of it as far as with coroners and their assessments of when quality of life decisions are being respected, which they were in both these cases. So I'm going to start with Ruth. So Ruth was 74. She'd had a stroke of many years standing. She came into hospital for an unrelated situation, but when she was in hospital, she was reviewed by a speech pathologist who recommended that she should be on a pureed diet and a thickened drink. Ruth said, thank you very much, no thank you, and it was then negotiated with her, what she felt she could cope with eating, and so she chose a soft, easy-chew, cut-up diet, which one has to say she had previously been eating at home before she came into hospital. So she was then transferred to another care situation. All of her information was sent, everything was received, everybody was on board with her request. And then 2 weeks into it, she requested chicken nuggets and chips for dinner, and the carers in the kitchen, so our marvellous catering people, knew that wasn't the texture modified diet she should be on, and so they queried that with the RN. The RN, based on a quality of life decision-making process, said, I'll give her the chips and chicken nuggets and I'll try and modify it when I'm with her. I'll go in and chop it up and get it as soft and cut up as possible. So that was all seemingly fine. The food was delivered to Ruth. The nurse never turned up. The food wasn't modified. Ruth choked. She used her emergency bell. People arrived immediately, but they were unable to save her life. So I think we're probably getting a bit of an idea now which one it was that the coroner was not happy with. So let's just have a look at Ian's a bit, because then we'll know what the coroner wanted or why, in a similar situation, Ian was such a different response from the coroner. And in Ian's situation, it was things like the fact that he'd made that decision. Everybody knew what the decision was. So everybody knew what the decision was. Everybody knew what their boundaries were. He had family members and friends bringing food into the care facility that were not texture modified. The facility, even though Ian didn't want to eat it, provided every meal his recommended texture modified diet. So he had a choice if he was feeling tired or not really able to cope with texture, he would get that, but he also had fruit and lollies and things like that available to him. There were documentation was in place. There were no decisions that were made to change the process for him unless he and his spouse and the staff were all consulted on it. So it was a much different scenario where all of the things that we expect in supported accommodation were certainly in place and were available to Ian, but they respected his quality of life decisions, which kind of happened with Ruth, but there wasn't the joint conversation. The nurse didn't go and ask Ruth why she wanted chicken nuggets and chips that night, which may just have been that she didn't like what was the texture modified meal that was on offer. So across the board, when I look at coroners' reports where quality of life decisions have played a part in them, what I need to say about it is that coroners are lawyers, that they have legal background. So they are absolutely on board with people making informed decisions around refusal of treatment options. They don't bat an eyelid at that, it would seem, that is totally acceptable to them. What is not acceptable to them and what they come down absolutely hard on is if we, in allowing people, or at least providing people with what they're requesting, do not do risk mitigation around those quality of life decisions. So not everybody rejects everything. They're usually only rejecting texture modified diets. So if they're rejecting texture modified diets, then they get offered supervision, they get offered, assisted feeding, whatever it is. So everything we do for risk reduction has to be in place as far as a coroner is concerned, as far as we have the capacity to do that. But what we do in that area, then the boundary is quality of life. So quality of life is the major decision-making process, and then we reduce risk within the boundaries of that. So it was very interesting to see that come out in coroners' reports. It's not the job of the coroner to report on our brilliant care of people's choices. Their job is to check whether there was anything that could have been done that wasn't done that caused the death. So they don't then write a report saying, well, it was a quality of life decision that meant the person died. Their finding will be, no, everything that was covered that could be covered within the risk framework that the person allowed us to do given their quality of life decision. So I'm hoping that might sort of give us a bit of reassurance about that quality of life reasons can be respected. We just need to have all the ducks in place with our processes, with our documentation, and with providing as much risk support as we can within people's quality of life. And I'm going to say a caveat to that. We need to look at people as individuals, not write policies that mean everybody. So we're back to person-centred care, because we start getting into trouble if we make really large policies that tries to encompass everybody's decision around quality of life. Whereas when we start looking at duty of care and the ethics and therefore the roll-on legality of it, we really need to come back to the individual and make sure we're looking at that individual as well as having these overarching policies and stuff, because as you can see with Ruth and Ian, very similar cases, but very differently managed. And so we've got to try and compensate for both those issues. So getting to near the end of this session. So for those of you who are still hanging in there, thank you for that. End of life and dealing with the technicalities. Now, this is moving more into the resuscitation issue. And one of the things that has come up is increasingly coming up to be sorted out is for people with life-limiting illnesses, if they don't want resuscitation, does that include choking management? And so I'm probably going to flip through a couple of slides just because of the time to just give you a bit of an overview on this and sort of get the critical parts for you. So don't worry that you're missing out on anything particularly interesting. We can come back to anything. I think I might flash quite a few through because I want to come down to what the crux of the matter is. There is the position that if someone chokes, resuscitation is not, that everything must be done. Choking is an unexpected accident that is reversible in some cases, requiring first aid and therefore exempt from not for resuscitation directives, that it's our duty of care to provide that first aid. And certainly looking at coroner's reports between 2000 and 2010, vividly I remember one coroner saying there will never be a time when, something like choking won't require, we do everything. However, look at the next kind of definition of choking. Chokings are not unexpected event due to known swallowing difficulties and potential difficulties with reducing risk, particularly in the face of some quality of life decisions. So if choking is expected or is a possibility, then why can't people make a decision about whether they refuse the CPR, in brackets, resuscitation element of it? And when we're looking at that question, we have to look at why do people refuse resuscitation and is choking any different from that? And the reasons people often refuse resuscitation is because they don't want to be resuscitated and potentially, and we know this from research, come back with more disability or additional disability from what they're already experiencing with their life-limiting illness, or they don't want to prolong their life-limiting illness. So the dilemma that we're having in this situation at the moment is around those definitions of quality of life, of resuscitation and choking, first aid. There is a clinical guideline that has been put out by the Aged Care Quality and Safety Commission, who on choking said you should ensure your staff are aware that an advanced care directive not to resuscitate does not mean first aid shouldn't be performed when required. So this made me very twitchy, and I contacted the Aged Care Quality and Safety Commission and said, these are what people are telling us that we want in their end-of-life plans, that they don't want resuscitation and they want that applied to choking. And it was really interesting. 5 fabulous people spoke to me about this, and this had come out of the fact that people were not doing the initial part of first aid because they thought they weren't meant to, because the person was not to resuscitate. So they weren't doing that initial part of hitting the person on the back and doing chest thrusts to dislodge the obstruction, which would mean that the choking event was totally reversible. So, we had a big talk about this situation of CPR, whether we go on to do CPR in a choking event. And this is Tasmania here, so I apologise if this is not in line with the issue, the things that you have in your state, but it would be worth checking. That a binding provision in an advanced care directive is one that has to be followed, but it only has to be followed if the advanced care directive comprises a clear and unambiguous refusal of withdrawal of a particular healthcare process. So our way to, I think, continue to explore this area and discuss this area is that we, with choking events to cover everybody, if it's not specified in the advanced health care directive that the person doesn't want resuscitation in the case of choking, then we are in grey territory. And I think that compromises and puts carers in a very difficult position. So it's a space that we still need to have discussions about, but that seems to be where it's sitting at the moment, that if we consider CPR as resuscitation, then we need to indicate in an advanced health directive that for the person, if they're really serious that they don't want that done, in the case of choking, they need to include that in their care directive. And I've had some discussions with ambulance people about that, and they've expressed their challenges with that as well. So I'm aware that we've got about 3 minutes to go, and I haven't left as much time for questions at the end as I had hoped, but we've probably got one for one or two. And so I'm not sure, Luke.
Thanks, Megan. Yeah, no, I was just checking the Q&A, and there's actually no additional questions. So we've probably tied off a lot of the questions that we were expecting in your presentation. So what I might do is I might allow, if anyone does have any additional questions that they'd like to ask Megan, that I will drop my email to them and they can pass it on to me, who I can then forward it on to Megan to answer it outside of this session. But thank you, Megan, for the presentation. It was very informative and engaging. So thank you firstly for presenting and taking the time with us today. It was really great. I just want to let the audience know to stay informed about our upcoming and online and community events. Please visit our website at powercaretas.org.au. Our next speaker series is with Rebecca Lyons, who will be discussing, as part of Dying to Know Week, how to look at home funerals in practice. The session will be held on the 14th of August at 2:30. So registrations, you can register on our website. So you can scan the QR code or visit the website to register today.
And
thank you, everyone.
Yeah, well,
yes.
Just thank you, everyone, for being here today. Probably didn't do my timing as well as I would have liked, but please contact me via email or phone number. Luke's going to pass that on to you. It's a challenging topic. I hope I haven't confused you. If I have, then please ring and tell me and I'll try and unconfuse. And, you know, I'm here as a support person. If you're struggling with these issues, I won't always have the answers. We'll always be sort of looking at whether we have to check in with other people for legal stuff and duty of care stuff, but very happy to engage in the challenges with you. So thank you, Palliative Care Tasmania, for the opportunity of connecting with people today and your wonderful support, Luke.
Thank you, Megan. I appreciate you.
And Kate on the side, who's made sure I make terrible debacles here. So thanks, everybody.
No, that was wonderful. And again, I appreciate your participation, and I hope everyone found the session really valuable. If anyone does have any feedback about the speaker series, please complete our survey. Your feedback is crucial in helping us provide relevant and valuable events such as today's session with Dr. Megan. You can scan the QR code. I will also send you a link to complete the survey via email. So if you don't have time to scan it, do not worry. You will have some time this afternoon to receive that. It takes about 2 or 3 minutes. So we would greatly appreciate you filling out that survey. Before we all depart, I would like to just extend a special thank you to all the PCT members who are joining us today. If you did enjoy today's event, the best way to connect with Palliative Care Tasmania is by becoming a member. Members will have access to today's event recording, which will be made available via the member login. You can scan the QR code to become a member today, or just visit our website. It takes about 5 minutes to sign up. It's really simple. And just lastly, the nature of the topics that we do discuss can sometimes raise complex, powerful and raw emotions. So I do encourage you all to keep checking in with yourself today. Thank you again, Megan, and everyone who joined us today. Really appreciate your time and your engagement. And I hope to see you all at our next speaker series. And have a really lovely Thursday.